Hello everyone and welcome back to my channel. So we have discussed the C-section in the last video. In this video we are going to discuss the anemia in pregnancy and folate deficiency anemia. So the common questions that are asked in the exams are that what are the different methods of treating iron anemia and the deficiency anemia in early pregnancy. Another question is that there is a G10P8 with 20 weeks pregnancy comes to antenatal clinic with HB of 7 gram per dl. The investigation, the causes, the types, and the management. Another question is that there is a multigravida presented at 36 weeks pregnancy with 8 gram HB. So define anemia. What are the effects of anemia on fetus and the management? Okay. Uh, PGHB 8 gram per day, HB 8 gram or common types of anemia, difference between iron and folic acid deficiency anemia, and what are the investigation options. So first of all, what is anemia in pregnancy? It is a condition in which there is deficiency of HB or RBC. How is anemia caused? In pregnancy, plasma volume expansion that is 50% greater than the red cell mass. This results in physiological dilation with decreased HB and hematocrit. Now the anemia, if HB is less than 10.5 gram per dl in pregnancy, MCV and MCHC is normal. The normal pregnancy has 2 to 3 folds increased requirement of iron and 20-fold increased requirement of folate. Now we are having different types of anemia. These are microcytic, macrocytic, and hemolytic anemia. The microcytic anemia are MCV less than 80 femtoliter. There is iron deficiency anemia and thalassemia. The macrocytic anemia are folate deficiency anemia and vitamin B12 deficiency anemia. And the hemolytic are sickle cell anemia. In macrocytic anemia, the folate is greater than 100 femtoliter, and in the hemolytic, the MCV is 80 to 100 femtoliter. Now, specifically the iron deficiency anemia, it is the most common type of anemia in pregnancy, and it is about 90%. The anemia is microcytic hypochromic RBCs. Now, the risk factors are the increased requirement during pregnancy, impaired abortion, malignancy, and chronic bleeding. The dietary the basic on which the diagnosis of the anemia is done is that first of all, in iron deficiency anemia, MCV is decreased, that is 80 femtoliter, MCHC is decreased, and serum ferritin and iron is decreased. While the red cell distribution width is increased, total iron binding capacity is increased, and transferrin is increased. So this leads to the diagnosis of the iron deficiency anemia. The symptoms are pallor, weakness, lassitude, and palpitations, fatigue, and constipation. Now, in iron deficiency anemia, there is no effect on fetal complication as iron actively crosses the placenta. The prevention is the daily supplementation of 30 mg of element iron and 1 tablet of the ferrous sulfate, that is 325 mg contains 60 mg of element iron. Encourage the woman to have green leafy vegetables and meat and poultry. And vitamin C increases iron absorption and T decreases iron absorption. So now we are having the management option for iron deficiency anemia, that is treated by oral supplementation iron, any ferrous iron supplement like ferrous sulfate 325 mg, and give parental iron in those that cannot tolerate oral preparation. Parental iron is given which corrects anemia more rapidly, and laboratory responses parameters are taken. Reticulocyte count is the first indicator to change, and it should increase within 3 days. HB hematocrit increased slowly and should increase about 10 to 14 days. Okay, so we have discussed the anemia in pregnancy, that it is a condition in which there is deficiency of HB or RBC. Then we have discussed that how anemia is caused. Then we have discussed that anemia is diagnosed if HB is less than 10.5 gram per dl, and in normal pregnancy the requirement increased to 2 to 3 folds. Then we have different types of anemia, which are microcytic anemia, macrocytic anemia, and hemolytic anemia. So anemia in pregnancy, page number 114. Okay, so the microcytic anemia are iron deficiency anemia and thalassemia, and the macrocytic anemia are folate deficiency anemia and vitamin B12 deficiency anemia, and the hemolytic anemia is sickle cell anemia. The iron deficiency anemia is the most common type, and the risk factors are increased requirement during pregnancy. The basis on which that anemia is diagnosed is that the MCV, MCH, and serum ferritin decrease, and the red cell distribution with total iron binding capacity and transferrin increases. The symptoms of iron deficiency are pallor, weakness, lassitude, palpitations, fatigue, and constipation. Now, the prevention for the iron deficiency anemia is the daily supplementation, that is 30 milligram of iron, elemental iron, and 1 tablet of ferrous sulfate. 325 mg contains 60 mg of the elemental iron, and encourage women to have green leafy vegetables, meat, and poultry. And then the management options are that treat by oral supplementation, any ferrous iron supplement like ferrous sulfate, and give parental iron in those that cannot tolerate oral, and parental iron corrects anemia more rapidly. Okay, now specifically coming towards the folate deficiency anemia. So it is also common in pregnancy, that is in 5% for pregnancies folate deficiency occur, and it is macrocytic RBCs with hypersegmented neutrophils. Uh, Folate deficiency anemia is macrocytic anemia. Now the risk factors are poor nutritional status, hemolytic anemias, hemoglobinopathies, and drugs which are anti-epileptics, antibiotics, and anti-cancer drugs. Then how to diagnose the folate deficiency anemia? In this case, the MCV is greater than 100 femtoliter, MCHC is increased, and plasma homocysteine is increased. Serum folate level is decreased, RBC folate level is decreased, and pancytopenia is decreased. Now, the complications of folate deficiency anemia are maternal and fetal. The maternal are loss of appetite, weakness, irritability, and headache, and the fetal are low birth weight and neural tube defects. Now, the management options are that folic acid amount 3 mg per oral daily is given, iron supplementation is done, weekly measurement of the laboratory response parameters is done, reticulocyte count and HB hematocrit is done. The prevention is that folic acid is given pre-conception and in early pregnancy to reduce the risk of neural tube defects, and folic acid is given at the dose of 400 mg per day in general population. Folic acid should be 5 mg in women with high risk of neural tube defects, which includes patients on anticonvulsants, previous child affected with a neural tubal defect, and women with hematological disorders. Now, the extra info or criteria is that trimester wise, the HB in gram per dl and the requirement. In the first trimester, the requirement is less than 11 HB gram per dl. The HB of a pregnant lady should be 11 HB gram per dl in the first trimester. In the second trimester, it should not be less than 10.5, and in the third trimester, it should not be less than 11. So these are the requirements. Now, the other causes are the lack of dietary intake, that is multiple pregnancy, and increased requirement, smoking, excessive alcohol consumption, and anticonvulsant medications, and short spacing between two pregnancies, and previous history of menorrhagia. The investigations are that the general list is on the clinical features, that is peripheral blood film, total iron binding capacity, serum ferritin, red cell indices, serum transferrin, bone marrow examination, plasma red cells folate concentration, and mother's stool examination and urine examination. Iron supplementation is done, that is iron supplementation recommended intake into 120 to 40 elemental iron per day. Intramuscular iron, that is sorbitol injection, increases absorption, and intravenously iron sucrose, that is AV cannula is given. Now, blood transfusion is done in emergency when it is not responded to medical treatment, anemic beyond 36 weeks, and excessive Hg. Now, the treatment of the underlying cause should be that it is hookworm infestation, albendazole, and for UTI antibiotics are given, for malaria antimalarial are given, and for hemorrhoid surgery is done. Care during pregnancy is continuous therapy for the treatment. So this was all about the folate deficiency anemia, that it is also common in pregnancy, and the anemia is macrocytic RBCs with hypersegmented neutrophils. The risk factors are poor nutritional status, hemolytic anemia, hemoglobinopathies, and drugs which are anti-epileptics, antibiotics. Then the diagnosis is made on the basis of certain things These are the in the folate deficiency anemia, MCV is increased and MCHC is also increased. Okay. So MCV is increased, MCHC is increased, and the plasma homocysteine is also increased in the folate deficiency anemia, while serum folate level, RBC folate level, and pancytopenia, these are decreased. The complications are both maternal and fetal. And then we have discussed the management options, that is folic acid is given, iron supplementations, and weekly measurement of the lab response. Then prevention is done. Extra info criteria are trimester wise, that is in trimester first, HB should be less than not be less than 11, into 10.5, and 3 11. The other causes of the folate deficiency anemia are also discussed. Investigations, such as general list on the clinical features, then iron supplementations, then the treatment of the underlying cause, which are hookworm infestations, UTI, malaria, and hemorrhoids, and then care during the puerperam. So this was all about the folate deficiency anemia. In the next video, we will discuss hypertensive disorders of the pregnancy, that is preeclampsia and eclampsia, and then we will discuss the about the gestational diabetes. Thanks for watching.